Everyone to this INICET 2022 November recall session. My name is Dr. SUNABHA and I did my MS in 2021 from JIPMER in Obs and Gynae. So I'll be discussing all the Obs and Gynae. So let's start with the most discussed question of this two session INICET this year, Vagitus uterinus. Well, Vagitus uterinus is just a fancy term. This describes when sometimes in rare occasions baby starts crying from within the uterus. The baby's first cry, the first breath, that happens while still crowning is happening, while baby is still in utero. So a cry of the baby in utero is basically called a vagitus uterinus. These are the kind of questions when you know you can answer, you don't know you cannot answer. So if you don't know, I would suggest don't take guesses, just leave this kind of questions. If you have prepared well, and if you have prepared well, and if you have other friends who have prepared well, they are also not knowing it, so don't just bother about it, leave and focus on other 199 questions. So next hot topic in this year's INICET is perimortem cesarean. So a perimortem cesarean, so it is whose mortem? The mother. So when the mother is dying, when the mother is in cardiac arrest, mother is passing away, collapsing, in dire emergency, note this word, in dire emergency, what we do is we cut open the mother's abdomen to deliver the baby, to give the baby a chance, whatever that baby has. So it is not done after arranging a OT. The mother is already doesn't have pulse, so she doesn't feel anything, so we don't need anesthesia. So we do it in labor room. I have seen it being done in eclampsia room. She had a cardiac arrest after throwing a fit. It can be done in casualty, I mean the emergency room, but never in OT. And the idea of this cesarean is to go as quickly as possible inside. So the best and easiest incision with the lowest blood loss is midline skin incision, and then upper segment uterine incision. Just cut open everything, grab the baby, take it out, and then shift the mother while the resuscitation is still continuing, and then save the mother's life. So incision is never phalansteal, it is skin midline uterus classical incision. Okay, so this is classical, this is a classical cesarean. So this is classical cesarean. This is one of the examples of a classical cesarean, and skin is also midline incision. Skin is midline incision. Okay. So next question. As per WHO, number of antenatal visits required for a positive pregnancy experience. So I believe you all know that as per WHO, total recommended number of AN visit is 8, and as per Government of India, this is exactly half, 4. So this you all know, I believe. So where all of you got confused is what is positive pregnancy experience, or is it something else? Nothing, my dear. This is something just to confuse you. The answer still remains 8. And if the same question comes for a Government of India thing, it would be 4. So the answer is 8. Nothing to bother about positive pregnancy experience. WHO in their guideline writes positive pregnancy experience. So the question comes. Okay. Next important topic. This is slightly concept based. So dating of a pregnancy, that is assigning the correct EDD from LMP. So here what I want to emphasize is LMP, you all know, is the last date of last normal menstrual period. Last date of last normal menstrual period. So this, sorry, this was the question, last. This was wrong. So it is the first date of last normal menstrual period, and this is what you should know. The EDD is LMP forwarded by 9 month 7 day, provided the lady has a regular 28-day cycle, so that our calculation is reliable. She is not using any hormonal medication, medication, and lastly she has to be sure of date. So if these three criteria are fulfilled, it is called a good dating. Now we all know the best dating tool is a first trimester ultrasound. So if these three is there, it is a good dating. If there is a first trimester ultrasound and it is corresponding with our calculated EDD from Naegeli's rule, which is 9 months, add 9 months 7 days. So if it corresponds with our EDD, that is called an excellent dating. So excellent dating is good plus first trimester scan. Uh, if you ask what if they do not correspond, then we have to calculate by the first trimester ultrasound scan, and then it would be simply a wrong date. So there was one more question on early pregnancy signs. It was probably a mix and match question. So you have to match with which sign is which one. So we should understand that the early pregnancy signs are due to progesterone. Progesterone is the hormone that sustains the pregnancy, and progesterone is a smooth muscle relaxant and it dilates all the blood vessels. So when the blood vessels are dilate, the venous engorgement will happen, and the vagina, which is very vascular, will obviously have a dusky hue, and all this placental dominance and progesterone dominance is maximum by 8 weeks, and progesterone is the one that causes lower esophageal sphincter dilatation and hence the morning sickness, the vomiting of pregnancy, because that helps in the reverse peristalsis. So these all is by 8 week. Nausea, vomiting maximum same duration 8 to 10 weeks. So what is Aussie sign? Same, hyper circulation. So fornices will have higher vascularity, higher vesicular flow. So there will be pulsation felt through the fornix. Well, what is Goodell sign? Goodell sign is softening of the cervix. So cervical smooth muscle layer is basically influenced and dilates. It loses its tone and becomes lax. So that is the softening of cervix. That is Goodell sign. So what is 2-3 more signs I want to discuss. One is Piscasex sign. So when the uterus is huge with full baby in it, uterus will be big. So you won't be able to appreciate whether placenta is here or here. But when the uterus is small, the placenta is implanted not exactly here. It will either have a left dominance or have a right dominance. So that side uterus will be more prominent. It's an 8-week size uterus. So it's a small uterus. So you will be able to appreciate that one side is slightly bigger than the other half of the uterus, the other side of the uterus, and that is called the Piscasex sign. Hager sign is you can insinuate the fingers on a bimanual examination, which is present only 2/3 of pregnancy. Now Palmer sign, you know, the first trimester ultrasound is all or none phenomenon. Like the pregnancy kind of assesses whether the fetus will go with and if it is a congenital anomalous fetus or a genetic defect is there. Most common cause of first trimester abortion is genetic defect. So when the uterus senses that there is a genetic abnormality, it just expels out. So basically what happens is a first trimester uterus doesn't know whether to expel the product. Is it not unfit and to be expelled, or it is a fit product of conception and it will continue the pregnancy. So basically regular rhythmic contractions like a preterm labor or an abortion will be there once it is chosen. Once the fetus is chosen by as early as 4 weeks to 8 weeks, when the fetus is chosen to go in the long run, the contractions space out and the uterus becomes absolutely calm to help the pregnancy. There were questions, multiple questions on CTG NST. So here I want to clear some concepts, because CTG and NST in clinical postings is often used interchangeably, but they are not. So what is CTG? CTG, C stands for cardio, so fetal heart rate. So fetal heart rate. And T stands for tocos. Tocos. So tocos is contraction. So tocos is contraction. So in CTG, we measure fetal heart rate and we measure contraction. So the graph goes like, here is the contraction area. So it is like contraction, uterine contraction, uterine contraction, like that the graph grows. And on the top half, there will be fetal heart rate. So what is NST? NST is non-stress test. So what is stress? Stress is nothing but labor. So when the uterus is acting, when the uterus has contraction, we do a CTG, so we can see both uterine contraction and the fetal heart rate pattern. Whereas in non-stress test, that is when labor is not there, uterus is calm, we just assess the fetal heart rate. So if you see there is only fetal heart rate pattern, it is not CTG, it is an NST, it's a non-stress test curve. Whereas if you can find both fetal heart rate and contraction are there, it is a cardiotocograph. So basically CTG minus toco is NST. I think that was the image based question. Many of you told that the image was blurry, but the image didn't have uterine contraction. That's what I collected from my sources. So now what are the CTG patterns? CTG patterns are really very simple. See, if this peak and the drop in the fetal heart rate corresponds in the same line, if they are in the same line, then it is an early deceleration. Early. If the deceleration, the dip in the fetal heart rate comes late compared to the contraction below. So that is called a late deceleration. If both are there or the deceleration patterns are coming erratically, then it is a variable deceleration. Variable deceleration can be here as well. So this is variable deceleration. And there is one more kind of deceleration, that is prolonged deceleration. So it doesn't go with the contraction anymore. It falls and remains fallen. Okay, prolonged deceleration. Prolonged deceleration is like fetal cardiac arrest. It falls and it remains fallen. It is like an emergency indication for an emergent cesarean section. And there is one kind of deceleration that can be made out on NST, that is the spontaneous deceleration. Spontaneous deceleration which doesn't need a contraction. The fetus is so much in hypoxia that even without contraction the fetal heart rate drops. So 5 types of deceleration: spontaneous, early, variable, late and prolonged. Prolonged is when the fetal heart rate doesn't peak for more than 2 to 3 minutes. So how to remember what is for what? What comes early in the labor or early in the delivery? What comes out the earliest? The head, unless it's a breech delivery, but mostly it is the head. And what comes late? What comes the last? The placenta. So early deceleration is because of head compression. This is just for remembering. Early deceleration is about head compression, whereas late deceleration is about a uteroplacental insufficiency. It's a placental cause. The placenta cannot oxygen the baby enough. And what is a variable length? The cord. So variable deceleration is about the cord compression. Chalo, moving to the next topic, biophysical profile. Biophysical profile is often done to assess the movement on the fetus. So a biophysical profile is done for 20 minutes real-time ultrasound, sometimes extended to 40 minutes. And what all fetal movements are seen? So fetal breathing movement is seen. Fetal breathing movement is seen. What all movement can happen in the fetus? Body movement can happen, so gross body movement. Gross body movement. So what are the gross body movements? When the fetus turns on its sides or folds itself, that is gross body movement. And there is one other type of movement that is called tone, which is basically like the fetus flexes its biceps or flexes its hip or extends its knee. So these small muscle flexing, muscle tone movements are known as tone. So these are the 3 ultrasound components of biophysical profile. And one more important component, ultrasound component, is AFI, amniotic fluid index, the amount of fluid that is the baby in. So there is one more movement of the fetus, right? The cardiac activity, which is seen on ultrasound. But remember, cardiac activity on USG is not included into biophysical profile. We see the cardiac activity on a more longer scale through an NST. Yes, NST, non-stress test. So non-stress test is there. So what are the fetal movements? Cardiac activity, but we don't see it on USG, we see it through the NST. What are the other movements? Breathing movements, gross body movements, tone, and what helps the fetus to move? What is the media of movement? That is amniotic fluid volume or the amniotic fluid index. Now remember, there is something called a modified BPP. Modified BPP, which is a simpler form of BPD, because BPD is painstaking to measure, takes long time, it needs operator skills. So what is modified BPP? Modified BPP is simple. It is NST and AFI. This is NST and AFI. That is modified BPP. Coming to the next question, a very basic question, events of the normal labor. So let me not go into the details of labor, just naming the events step by step. Engagement followed by flexion, and then internal rotation with flexion, then flexion with descent, then extension with descent, then restitution. External rotation, basically restitution is a part of the shoulders internal rotation, and then trunk delivers by the lateral extension. It's a normal labor. What I want to focus here is flexion and descent are not two events, but it's a continuous process. Engagement happens, then flexion starts. When internal rotation happens, flexion is continuing to happen unless this extension phase comes. And same thing, descent. It doesn't so happen that internal rotation is happening, at that time no descent is happening. Flexion and descent keep on happening till crowning. Crowning per se is an event and is a demarcated point, it's an arbitrary point. It is not exactly a procedure. It is a point when descent happens so low that the fetal head doesn't recede back. That is crowning. So crowning is basically an arbitrary point. It is not exactly a step of labor, but if you are asked in the question, the order is what I have shown in this. Coming to one more very basic thing, active management of third stage of labor. Active management of third stage of labor. Third stage of labor is basically delivery of the fetus, from delivery of fetus to placental delivery. So that is, so AMTSL, I will go into a little bit of history here. AMTSL classically had 4 points: uterine massage, uterotonic drug, and placenta delivery. Placenta delivery by controlled cord traction. Controlled cord traction, which is also known as modified Brand-Andrews maneuver. So over the time, it has evolved in a way that WHO now recommends controlled cord traction only to be done when specialist birth attendant is present. When specialist birth attendant is present. Uterotonic of choice is oxytocin, but where oxytocin is not available, methergine can be given in certain scenarios. Misoprostol 600 microgram sublingual can also be used. And what is the new drug in the block is carbetocin. So I'm kind of surprised that there is no question on carbetocin as far as I have collected on this year's INICET. But carbetocin is the new drug which will replace oxytocin very soon. And what about uterine massage? Uterine massage is no longer there, but it has been replaced by intermittent assessment of tone. Intermittent assessment of uterine tone. So you don't waste energy by actively massaging the uterus. unless you feel there is a atonic PPH or there is an uterine atonia. So while you are managing the labor, just time to time check whether the uterus is contracted or not. If uterus is not contracted, it is atonicity, and uterine atonicity has to be managed in a different protocol. But in normal AMTSL, uterine massage doesn't include anymore. But if you are asked in a question with an obvious outlier, then you choose uterine massage for now. As of now, you take uterine massage as a valid option. And in this regard, when AMTSL was first proposed, it was not a triangle but a square, and that square had one more end called early cord clamping. But that early cord clamping is now taken out of the scope of AMTSL. Currently, delayed cord clamping is what is recommended. But then delayed cord clamping, remember, delayed cord clamping is not included as a step of AMTSL. It's a general recommendation, delayed cord clamping. But delayed cord clamping is not a part of the triad of active management of third stage of labor. So third stage management, 3 steps: uterotonic, assess the uterine tone, and controlled contraction if you are a specialist. If you are not a specialist, let the placenta deliver on its own. So there was one more question on dystocia. Dystocia means an abnormal labor. So there were different indicators of dystocia, as I remember, like high vertex station. High vertex station means head is not naturally coming down, so that is definitely comes in abnormal labor. So most confusing options, as I have collected, is multiparity, and there was one more option was epidural or neuraxial block something. So this is a bit of a complicated question. Now epidural is classically known to slow down a labor, but recent evidences are showing that epidural does not hamper with the labor. So when multiparity is there in an option, which is actually a facilitatory factor for abnormal labor, which is a facilitatory factor for good labor, multiparity experienced uterus, then epidural would be the answer that is causing dystocia. But in the same question, if the answer was if the option was grand multipara, overstretched uterus that has been worn out over time, a grand multipara can have dystocia. So in that question, if epidural is there, then that question is based on the latest evidences that epidural does not hamper with labor and grand multipara will be the option. So I'm not sure which one was the exact question, so I'm discussing this. Now, coming to one of the hot topics of obstetric emergencies, preeclampsia. So, let us revise the definition of preeclampsia, which is given by 2018 ISS HP or by 2019 FIGO guidelines. Preeclampsia is hypertension, either gestational or chronic, with evidence of systemic involvement. So the old definition that hypertension plus proteinuria is preeclampsia is gone. Proteinuria cannot be there as well, and the severity of proteinuria doesn't correspond with the severity of preeclampsia. So 2 plus proteinuria, without going much into debate, 2 plus proteinuria is a criteria for preeclampsia, but 3 plus is severe or 4 plus is more severe. It is not like that. There are other parameters like low platelet, raised creatinine, altered liver enzymes, and cerebral symptoms. Cerebral symptoms are scotoma, that is blind spot, headache, most common, blurring of vision, headache. These are the cerebral symptoms. So all these are counted in preeclampsia with severe features. BP more than 160 by 110 is a severe feature. So this is called imminent eclampsia, and in all imminent eclampsia we have to give Maxel. Now this is out of our scope to discuss the Maxel regimes here, but the target Maxel MACSELF concentration in 4 to 7 milliequivalent per liter in bloodstream to achieve the anti-convulsion activity or the seizure prophylaxis activity. So the beauty of MACSELF toxicity is MACSELF toxicity pattern is very predictable. So when it goes beyond 7 and around reaches 10, the deep tendon reflexes will go. Deep tendon reflexes will go. When it goes somewhere between 10 to 15, there will be respiratory depression. So respiratory rates will come down. And beyond 15, there will be cardiac arrhythmias. There will be cardiac arrhythmias. And beyond 20, it will be arrest. Beyond 20 will cause arrest. So when we give in your wards or in eclampsia rooms, you give MACSELF, you monitor knee jerk, you monitor respiratory rate, you obviously monitor BP, and you monitor pulse rate or pulse rhythm. At the same time, obviously you all know that we also measure urine output. But remember, the urine output we measure is because MACSELF doesn't cause any renal impairment. But MACSELF gets excreted through the renal system. So if we see the urine output is low, that means that MACSELF which was given in the last dose is not adequately cleared. So giving a second dose on top of that remaining MACSELF might cause toxicity. So from that point of view, we measure urine output. MACSELF doesn't have any renal toxicity, but MACSELF do get excreted through the kidneys. One more thing I would like to add here, calcium gluconate. Calcium gluconate infusion is the antidote for MACSELF and antidote for MACSELF toxicity. And there is a rule of 10. There is a rule of 10. So 10 ml of 10% calcium gluconate over 10 minutes. Okay, 10 ml of 10% calcium gluconate over 10 minutes. That is the regime of calcium gluconate when used for MACSELF toxicity. Now, one more hot topic, antepartum hemorrhage, and the two most important differentials are placenta previa versus abruptio placentae, because both can cause APH. When placenta previa, it is painless. This bleeding is painless, and in abruptio, this bleeding is painful. This is the most striking. This is the most striking. So the pain is basically due to what? Uterine contraction. So in abruptio, uterus goes into a hypertonic contraction. It is kind of a tetany of the uterus. The uterus becomes contracted and remains so. So in APH due to placenta previa, uterus will be relaxed. Whereas in abruptio placentae, it will be a tense, tender uterus. And what is abruptio placenta due to? It is premature separation. So behind the placenta is separating from the uterus. So there is a bleeding behind the placental surface. And that bleeding is pushing the uterus up. So fundal height will be more. And since there is a intractable blood loss, there will be unexplained sudden pallor in the woman who is having abruptio placentae. Whereas in APH for placenta previa, the blood loss is massive and the lady will suffer from syncope. So that is what in general examination and history we should take care, that if there is syncope, it is more indicating of placenta previa, whereas it is unexplained sudden pallor, this is suggestive of abruptio. Since previa the placenta is bleeding, before torrential bleeding it can bleed a little. So that is known as warning hemorrhage. There is no such event in abruptio placenta. Warning hemorrhage was probably there in the options to rule out, or like all except type of question it was. So warning hemorrhage is a sign of previa, not of abruptio. And obviously there is a clot behind the placenta, there is bleeding behind the placenta. So uterus USG might show retroplacental hemorrhage, though it is not universal. And here USG is almost diagnostic and low placenta will be seen. Previa is more common with a woman with a previous history of cesarean delivery, whereas abruptio is common in a mother having any hypertension disorder of pregnancy, either preeclampsia or gestational hypertension, chronic hypertension, just to see the cue in the history. So this year I think a lot of focus was on placenta, how much grams it would be, how many vessels, how are the vessels inserted, what are the types of placenta, what is the normal weight. So placenta is around 500 grams, or it is 1/6 of the fetal weight. It's either 500 gram or 1/6 of the fetal weight. A normal placenta, its thickness is 4 centimeter, 2.5 to 4 centimeter, so almost 1 to 2 inches. The question I think was succenturiata placenta, which is one placenta, one major lobe of placenta connected to a smaller lobe of placenta. The problem with placenta succenturiata means succession, means after coming one placenta, another placenta successively comes. So this is one of the important causes of retained placenta, because we have taken the placenta out, we have seen the placenta is complete, but we don't know that there is one more lobe of the placenta. So this is one of the cause of retained placenta and PPH, atonic PPH. There was a question, I think it was related to the cord insertion. So let us discuss the cord insertion. If the cord is inserting directly on the edge of the placenta, it is called a battledore placenta. The placenta is inserting at the edge. Don't confuse this with velamentous insertion of placenta or velamentous insertion of the cord, where the placental vessels comes and they branch out on a membrane away from the placenta, and that membrane goes and fuses into the placenta. So this is a basic difference. So this is velamentous or membranous placental insertion, and this is when this portion breaks or tear happens, the bleeding is from the fetus. So this is called vasa previa. If it is there presenting in the delivery canal, it can cause vasa previa and direct fetal hemorrhage. But battledore placenta is more associated, not associated with this kind of hemorrhage, but more associated with reduced placental flow or fetoplacental insufficiency. So one more thing, if we take a cross section of the placenta, this is cross section of the cord. So this is the cord, there is the vein, and there are two arteries. So remember AVA, AVA. So arteries are two, it's a 3-vessel cord. Normal cord is a 3-vessel cord. So one vein, two arteries. When you see on the ultrasound, the vein looks like this, and two arteries are seen here. So in USG, the cross section of the cord is also known as Mickey Mouse sign, right? This is the head of the Mickey Mouse and these are the two ears. So obviously embryologically most structures are developed in pairs. So there one question can come that this is left artery, right artery. So the vein is originally the left vein or the right vein. The answer is it is originally left vein. The right vein disappears. Remember, the left is left. The right vein disappears and the left is left. So it is AVA, two arteries and one vein, a 3-vessel cord. One more question on the placenta, protein hormone by placenta. So LH, FSH, estrogen and HCG was given to me as that's what I have collected. See, HCG is human chorionic gonadotrophin. So chorionic means chorion means placenta. So chorionic is the hormone that is definitely from placenta. Placenta secretes around 50-60 other hormones, but HCG is definitely the one. Next question on discussion is on primary amenorrhea, which is the possibly the single most important topic in entire gynecology segment. There has been multiple times this question has been asked on algorithm of diagnosing or the etiology of primary amenorrhea, but this time the very definition of primary amenorrhea was asked. So the most basic question in primary amenorrhea asked. So let us discuss the definition. A girl who is more than 14 years of age has still not attained menarche and not attained any secondary sexual characteristics. So basically a girl of 14 years who has not attained secondary sexual characteristics and menarche is primary amenorrhea, or a girl who is more than 16 years of age, secondary sex character has come but still menarche has not come. So that is the definition. And by secondary sex character we will see what is Tanner stage after a certain time. So Tanner 2 is what is secondary sexual development beyond Tanner 2. So let's see, 11 year with Tanner 1 breast. So no secondary sexual characteristics, no amenorrhea, but she is less than 14 years. Here secondary sex character has come and she is 12 years. So lot of time to 16 the cutoff. So lot of time to go till called primary amenorrhea. Tanner 5 breast, that is a developed breast. She is still less than 16 years. So these are all primary amenorrhea. Here we see a 14-year-old girl with Tanner 1 breast. So secondary sexual character is not there and menarche is not there. But she has reached 14 years of age. She has reached 14 years of age. So this is what we call a primary amenorrhea. So let us see the Tanner staging. Tanner staging happens for two things, breast development and pubic hair development. So here there is a interesting mnemonic, no body elevates two mountains in adulthood. So Tanner stage 1 is no breast development. Tanner's 2 is budding. This is elevation. This is secondary mounding, and this is the adult pattern. And for the pubic hair, the mnemonic is, so coming to the Tanner staging of pubic hair, the mnemonic is not a small cat. So N is no hair, cat refers, so small, sparse hair. C is coarse and curly. A is adult pattern except the thighs, and T is hair on the thigh. So this is the Tanner staging of adrenarche. So coming to the next topic, there was many questions as expected. Contraception, this is a single topic that you cannot leave in an exam. So there was a question on LARC. So what is LARC? Long acting reversible contraceptives. So what are they? Most importantly, copper T or other intrauterine contraceptive devices. What else? Implants, injections, anything which is long acting but can be reversed. On the other hand, the other option was some form of a sterilization. Sterilization, as we all know, even though it can be reversed, it is not meant to be reversed. That is what the catch is. It can be reversed, but it's not meant to be reversed. So this is a permanent method of sterilization, this one. So this is not an LARC. Coming to non-contraceptive benefits of OCP, age-old question. OCP is basically the one weapon the gynecologists use to treat practically any gynecological problem, be it premenstrual syndrome, menstrual irregularities, PCO, dysmenorrhea, endometriosis. Everywhere the answer is OCP. That is the single-stop drug for gynecologists. Apart from that, I want to focus on OCP. It prevents three cancers. Three cancers, and mnemonic is CEO. It prevents three cancers: CEO, endometrial, ovarian, and colorectal. These three cancers it prevent. The cancer which is predisposes to is cervical and vaginal or vulval. Mostly cervical. OCPs predispose to cervical cancer. But these are the three cancers that OCPs prevent. I'm not exactly sure about what was the question asked, but I think it was about one of the cancers. One more thing that OCP doesn't prevent is STIs. So for STIs, to prevent STI, you need barrier. Nothing except a barrier can prevent STI among the contraceptives. So there was that's what I collected. This was an option probably. So STI and cervical cancer are not prevented by OCPs. Trimester 1 MTP, yes, trimester 1 MTP is most commonly done by Mife-Miso standard combination or surgically by manual vacuum extraction or manual vacuum aspiration. Extra amniotic ethacridine is no longer available in India or worldwide possibly, but it was used classically as a trimester 2 MTP. Trimester 2 MTP. Now there is a, I am not sure whether this was really the option DNC, but surgical clearance of the uterine contents, which is more classically known as DNE or sometimes a suction evacuation, SNE, is definitely can be done for a trimester 1 MTP. It's a lesser invasive version of that is basically MVA, but DNC, if it was the option, I don't know, but DNE is definitely an option for MTP. Now DNC is basically a variant of DNE. So after evacuation we also do curettage. So this is one method by, if we do a DNC, let's see it in this way. If we do a DNC in a first trimester pregnant woman, the MTP will be done. So from that way you can see it. But extra amniotic ethacridine definitely is a second trimester MTP. Second trimester MTP is also done with PGF2 alpha, which is prostadine, So extra amniotic prostadine instillation or injection. One more is intra amniotic hypertonic saline infusion, intra-amniotic saline infusion. These are the techniques of second trimester MTP. Now, this year, what is the trend I have seen is a lot of question being asked on single topic fetal medicine. So, there were questions on non-immune hydrops, possibly the causative agent, but since this has been asked, I would like to discuss in a bit detail. So, what is a hydrops? So any two of these four has to be there. Any among these four, the pleural space, the pericardial space, the abdominal space, and a general skin, under the skin subcutaneous tissue, any two place fluid has to be there. It is accompanied by a placentomegaly. You can see the placenta is 1/6 of the baby usually. So you can see the fetus and placenta are almost of the same size. And you can see the grossly bloated up baby. So placentomegaly and polyhydramnios is associated, but remember those are not the criteria for diagnosing hydrops. Any two of these third spaces have to have fluid, either the pleural space or the pericardial space or the abdomen or generalized subcutaneous tissue. The least of etiology is non-immune hydrops fetalis. It's a favorite question in central institutes. Obviously, I'm pretty sure this is the question in JIPMER. In every round it is asked what are the causes of non-immune hydrops fetalis. So this list is extensive list. What I want to focus here, look at the list of infections: parvo, syphilis, cytomegalo, toxo, rubella, enterovirus, varicella, herpes simplex, coxsackie, listeriosis, leptospirosis, Chagas disease, Lyme disease. So this list doesn't have HIV and HBsAg and HCV. I mean, hepatitis B, HIV, and hepatitis C are not there in this list. That is what is significant, and that is from where the question has come, I believe. Just to complete the list, I will show the complete list. This is from the latest edition of Williams. Just look at it. Don't try to remember everything. Now, there was a question, I think, on the intrauterine fetal death eponymous signs. So there are 3 eponymous signs which I want to just name one by one: ball sign, Splanding sign, Splanding sign, and Roberts sign. I think the question was on Roberts sign. So what happens is the first sign to appear is fetal hyperextension of the fetus. So that is ball sign. Splanding sign is where the parietal bones of the fetus ride over one another, because the cerebral gray matter liquefies. Cerebral gray matter undergoes liquefactive necrosis. So once it is liquefied, the skull is basically compressed and one bone goes over the other. So that is Splanding sign. And when you see the great vessels in cross section, the arteries will have air after the death. Only the veins will have blood after death, because the blood which has been pumped from the heart, last pump of the heart, the blood has gone into the arteries, and then from arteries to capillaries, and then they have come into the vein and came back to the heart, and the heart never pumped. So arteries will not have blood. So what will the arteries have? Gas. So gas in the artery, the great vessels, is known as the Roberts sign. There was a question on diethylstilbestrol exposure in the mother. So this is typically, this causes a lot of things in a female fetus, but typically it always affects the female fetus. If it is a male fetus, no, it only affects the female fetus. So two major things. One is T-shaped uterus, and one more is vaginal cancer. So classically, vaginal cancer, as you all know, is caused by the HPV infection as well, and it is, if HPV is involved, it is squamous cell carcinoma. So in this case, remember, this is an exceptional case. So this is an adenocarcinoma. When it is due to DES exposure, it is adenocarcinoma. What type of adenocarcinoma? Clear cell. So it was kind of a direct question. Coming to the invasive fetal testings, I think in all both sessions question has been asked on it. So amniocentesis is when you take out the amniotic fluid under ultrasound guidance. All of these are done under ultrasound guidance. CVS is when you take a small biopsy from the fetal placenta itself, and chordocentesis is when you do take the fetal blood from by piercing the fetal umbilical cord vessels. So CVS is done at the earliest, and it is done between 11 to 13 weeks. Whereas amniocentesis is done between 15 to 20 weeks. Chordocentesis can be done anytime after 18 weeks, but usually not done before 24 weeks. It is done from 24 weeks. Chordocentesis is mostly done where hydrops is suspected. Chordocentesis is done where hydrops is suspected to assess fetal HB, or chordocentesis is done as a part of intrauterine transfusion. CVS and amniocentesis are both usually for genetic testing. These are done to do a fetal karyo. These are done to take out cell and fetal karyotyping. When at 13 weeks around we do the fetal first trimester aneuploidy scans. So if the aneuploidy scans are suggesting, we either do amniocentesis or do CVS based on the weeks and feasibility. So I think the question was well within this part. This is probably the toughest question in this what I have collected. So these are the options. Students, please confirm me if the options are correct. And I have done a little bit of research and found the latest evidences and guidelines. So what I have found is SSRI are known to cause all these. So let's see the options one by one. Persistent pulmonary hypertension, pulmonary hypertension. So this is caused by SSRI. There's no doubt about it. Now it can cause neonatal adaptive syndrome, and FGR, which is kind of like aspiration symptoms. So they will come as low Apgar, and these two will lead to, if happens, will lead to mental retardation or delayed neurodevelopment. What was the delayed motor development? What was the option? So this is a part of neonatal aspiration syndrome or neonatal adaptive syndrome, but ADHD is not well linked. Like I could not find any evidence with ADHD in the baby in later life and SSRIs. So this is a complicated question. I have consulted with my neonatology colleagues as well. Do let me know if you find contradictory evidence. There was one direct question on dilatation and curettage, surgical steps. So surgical steps are easy and meticulous. You do antiseptic dressing and dripping. Then you do a PV examination to reconfirmation PV, and then ASS plus ASD and evacuation of bladder. Then we do a reconfirmation PV. Then we visualize the cervix, put the sim speculum, the anterior vaginal wall retractor, and hold the upper uterine lips with the help of ovum forceps or a sponge holding not ovum forceps, with a sponge holding forceps, and then we insert the uterine sound. Sound is the first dilator. Plus it tells you whether uterus is anteverted or retroverted, plus it measures the uterocervical length for further instrumentation. So if you go beyond UCL, you have most probably perforated. Then comes serial dilatation, and then finally the curettage. Then the curettage. Finally, you check for hemostasis and remove all your instruments. Now, there was this question on iron therapy in anemia. I have just quoted this entire table from the Anemia Mukt Bharat Government of India operational guideline. So let us see. Anemia is defined as hemoglobin less than 11. So mild to moderate anemia and less than 7 is severe anemia. Now if it is Government of India says very severe anemia is less than 5 and severe anemia, just severe is 5.0 to 6.9. So severe, very severe, immediate hospitalization and transfusion. Now severe anemia. If it is less than 34 weeks, that is we have time to go, then iron sucrose or ferric carboxymaltose, that is IV iron, can be tried. If it is more than 34 weeks, that is we don't have much time now, then we have to hospitalize and give blood. Now coming to mild and moderate anemia, where we have a gestational age less than 34 weeks and she is compliant to oral iron, we increase the dose of oral iron and then reassess. If gestational age is more than 34 weeks or she is non-compliant to oral iron, then we give IV iron. IV iron, VO, iron sucrose or ferric carboxymaltose. So if somebody comes and tells you that ferric carboxymaltose is not there in the government of India guideline, that is wrong. Ferric carboxymaltose has come into the Anemia Mukt Bharat guideline. It is very much there and it is the preferred one currently. So let us move to another question on teratogenicity. So 4 drugs were given, and this is kind of a direct question. Match the following type of. So thalidomide, we all know, phocomelia, the great thalidomide disaster where baby is born without arms and legs or very short limbs. Isotretinoin, it is the vitamin A supplement that women take, men women both take, because acne problems. It's mainly the DOC of acne. So this affects the ears of the baby. So either a microotia or anotia. Chloramphenicol, again classical question, grey baby syndrome. And warfarin. Warfarin, remember, is an embryotoxic drug. Warfarin is not a drug which affects the fetus, but it's an embryotoxic drug. The feature which is seen is depressed nasal bridge. Depressed nasal bridge, but mostly warfarin is an embryotoxic drug. The embryo is damaged enough. It results into an abortion. So much of warfarin toxicity effect is not seen. Only thing that is characteristically seen in depressed nasal bridge. Turner syndrome, the question was, I think, pretty direct. So you should know what are the key things of Turner syndrome. Like if there is a short stature, then down Turner, many other symptoms of short stature. That is not a specific thing. But if somebody gives you an option like shield chest, that is classic of Turner syndrome. Low hairline, classic of Turner syndrome. Turner syndrome is XO, right? XO. 45XO. One of the X chromosomes get deleted. Shield chest, low hairline, webbed neck. So these are classic keywords of Turner syndrome. Bicuspid aortic valve leading to aortic stenosis or aortic regurgitation. These are the characteristics of Turner syndrome. Coming to the oncology questions that was asked, compiled both sessions. So there was a question on preventive oncology on HPV vaccine. So the question was basically on the components, the protein components of HPV. So let us just discuss 3 proteins, not going much details. E6, E7. These are the oncoproteins. These are the ones that leads to cancer. Right, these are the ones that leads to cancer. These are the oncoproteins, and one more is the capsid protein. This is the capsid protein. So this is the one against which the vaccine is developed. So I think that was the question. L1 is against which the vaccine is developed. You know, the vaccines are of 3 types: the 2-valent Cervarix, the 4-valent Gardasil, and the 8-valent Gardasil 9. Nonavalent Gardasil 9. Nonavalent Gardasil 9. You know, you should know the strains that it protects against. So there was question on vulva cancer risk factor. In one session, I think only the age factor was focused on, and the other one had this other session. The question was on all the risk factors. So age is a risk factor for all malignancies, most malignancies. So higher the age, higher the risk factor for a malignancy. So the higher age group that was given in the question is the answer. Then CA vulva is basically from HPV. So it is basically a squamous cell carcinoma. So same risk factors applies. Smoking, multiple partners, poor hygiene. Then it is Vulva starts with vulval intraepithelial neoplasia. Starts with vulval intraepithelial neoplasia. Just like carcinoma cervix starts with cervical intraepithelial neoplasia. Similar. So vulval dystrophy, dystrophic change precede the malignancy. So these are the common risk factors. There was an image-based question, I think, on dermoid cyst. So dermoid cyst, which is also known as mature cystic teratoma. If it is immature, if it has neural component, it is called immature, and that is malignant. But a dermoid cyst, which is a mature cystic teratoma because it has components of derivatives of 3 embryogenic layers, and mature is benign. It is usually unilateral tumor. It doesn't undergo malignant tumor, and it has hair, nail, everything. So if it has hair, the typical ultrasound feature will be like this. So this is called a dot dash pattern. And suppose here one point a teeth is there, or here one point a small bone is growing. So this has this kind of prominent areas, and those are known as Rokitansky protuberance. So if you see a tumor, ovarian tumor, which is having a area of solid echogenicity at one point and inhomogeneous opacities throughout the content inside the mass, then it is most likely a dermoid cyst or a mature. Now, because one area is heavy and the other area is not, it has the maximum tendency to undergo torsion. This is the tumor that has a maximum tendency of undergoing torsion, and if it undergoes malignant change, it is usually benign. But if it undergoes a malignant change, the malignant change starts from the Rokitansky protuberance. There was one more question on a concept called platinum free interval. Platinum free interval is a key concept in cases of ovarian cancer. So ovarian cancer, you all know the first line drug is platinum drugs, cisplatin. So from the completion of chemotherapy to recurrence to completion of chemo, this interval is called the PFI, or the platinum free interval. So how long patient is platinum free till the disease comes back? Ovarian cancer is a very recurrent disease. So 1 year, 2 year, 5 year, 10 years, it will come back. I have been in a cancer institute. So I have seen many people. Recurrence is obvious. Recurrence will happen. So the point is how long after the completion of treatment the recurrence happens. And if it is less than 6 months, it is called a platinum resistant disease. Whereas if more than 6 months, it is called platinum sensitive disease. So if somebody has a platinum sensitive recurrence, the treatment for the recurrent ovarian cancer will be platinum again, platinum re-challenge. Whereas somebody is platinum resistant, then they have to give the second line drugs. Second line drugs like liposomal doxorubicin, all these drugs can be given at that time. So platinum resistance is 6 months. Platinum sensitive is more than 6 months of platinum free interval, 6 months or more platinum free interval. And if on chemo somebody progresses, then that is called a progressive disease. Then we have to reassess and maybe change into the second line before completion of chemotherapy. It's a different issue I just discussed. So at the end of this, these are the questions that I could collect and manage. So at the end of this, I want to emphasize on one thing, that when INICET is combined exam of PGI, AIIMS and JIPMER. So you all know that PGI was a different pattern of examination and it had multiple correct answers. So since PGI has a stake in the question making, you will see the PGI pattern of question is coming back. There are questions is framed in a different way, but those are all like PGI questions, like multiple correct answers. So the era of single best answer type questions in INICET is, I think, probably gone, and be prepared for PGI type of questions. All the best. See